Today I'm gonna walk you through one procedure we did with Dr. Ignacio Scotto, one of my teachers. It's a through and through infrapopliteal and pedal arc revascularization. So we're going to be talking about a 59-year patient with a history of diabetes, hypertension, and smoking. His current condition started eight months before the procedure with an ischemic lesion that progressed to ulceration of the fifth toe of the left foot. After he received a toe amputation, which didn't go well, so he was referred to our hospital. This is what it looked when he get to our hospital. In our vascular lab, we analyzed, and at the physical exam, we find the clinical and typical findings of critical limb ischemia with monophasic Doppler signs and absence of distal pulses. On the vascular ultrasound, we found a very severe disease, but nothing specific. So we decided to take him to the cath lab, and we did an ultrasound-guided punction of the common femoral artery, of the left common femoral artery, and advanced a 6 French sheath. Afterwards, we did our first images. As you can see, we have a nice superficial femoral artery, but in the popliteal artery, we have an important lesion. After this, as you can see, we try to cross this lesion without doing any dissection, and to reduce any complication and assure a working area. We usually work in tibial vessels using a mesh 1 catheter passing through the femoral and giving support to the distal treatment. Afterwards, we can see the distal angiography that the patient was not a candidate for a retrograde access because he only had one vessel going down. So we decided to try the treatment of the anterior tibial artery. We decided to cross it with a support catheter and then 0.18 guide wire. Afterwards, we did a gently advance of the support catheter. We did a distal shot to see if we were intraluminal, and afterwards we advanced the catheter. These are images of the foot circulation. As you can see, we got an incomplete arch, pedal arch, so we decided to treat this arch. We changed the platform to an 0.14 guide wire and support catheter, and we tried to navigate through the pedal arch. After navigating and after advancing a support catheter, an 0.14 support catheter to the pedal arch, we managed to get out our guide wire through the ischemic lesion, and we clamped it with a vascular clamp. A mosquito clamp. That gave us support to give a treatment to this vascular bed. This is our treatment in the pedal arc. As you can see, we use, below the knee, we use lung balloons. We usually start with 2 millimeters or 2.5 millimeters balloons and extend it to the anterior tibial artery. Afterwards, we did another angioplasty until we reached the lesion in the popliteal artery. After this treatment, we decided to use a drug-coated balloon. And this is the result from the tibial vessels after the angioplasty of the distal limb. This is our final arteriographies. Before doing this, we have to lose the guide wire from the axis above, and after this, we can see a significant improvement. You can compare the first video with this one and the velocity of the flushing of the contrast in the foot. This is the lateral view, and this is the final result. Obviously, we had to treat the popliteal artery. It did not require any stent. And afterwards, we did debridement of the ulcer, and this is the final result 5 months after the treatment. So this technique requires of great support. Usually, we use in the superficial femoral artery a match 1 catheter. We use support catheters from the femoral to the tibial vessels, we usually use 035 or 018, and in the distal vessels in the foot, we always use 014. The guide wires, this technique would require a lot of guide wires. Most of the time, the tip of the guide wire will be bending and bending, and you will have to change it. Most of the time, when we get these results and when we can get a through and through, we do it with a common guide wire or with a Savion delivery.